Clicker's up there.
You guys see the timer?
Got it.
All right.
That'll tell you how much time you have.
I'm gonna leave this under here. What do we leave your flag?
What's that?
What do we leave your flag up here? You don't have to hold it?
I don't mind.
Okay.
Inspired. Right. Does everybody have the light in their eyes? Yeah.
We have to tell them.
I wish in the winter when I talk to them, I wish there was like some vitamin D that came from them.
Right.
Good morning. Morning to everyone. My name is Dr. Paul Early. I am the President-elect of the American Society of Addiction Medicine. We are delighted to have you all be here today, and we have a really great program for you. But before we begin, I think what we should do is give a round of applause first to the staff. What an amazing staff for what they do. And I don't know about you, but I'm sitting in my room looking out at the water and thinking, boy, we need to have this conference here every year. A great hotel and great staff in the hotel, so maybe a round of applause for the hotel as well. All right, so let's get started. In the past, we have traditionally examined federal policy issues during the public policy plenary. However, this year we're going to focus on the legislative and regulatory work outside of the Beltway. As the epidemic of addiction involving opioid use and opioid overdose deaths continues to devastate communities across the country, many state governments have turned their attention to strengthening their local addiction prevention services, treatment services, and recovery support services. As you will hear from our great speakers, no two states have taken exactly the same approach. There's value in comparing and contrasting what has worked well and what has been less successful. This will help us be informed advocate for the best practices when we get back to our home states. State government leaders are eager to enact policies that will make progress towards reducing the burden of the opioid epidemic. But that enthusiasm can be ill-informed or misdirected. So it is our job as clinician advocates to ensure state policy proposals reflect what we know to be effective prevention and treatment strategies. That's what ASAM is all about. As we saw with the health reform debates in Washington last year, we need to make our voices heard when policies may have unintended consequences for our patients' ability to access evidence-based treatment, and we need to be persistent in our efforts to dispel stigma and inform science-based addiction policy. Thank you to those of you who have taken action in the last year to let your members of Congress know your views, whether you called, tweeted, well, maybe we won't say tweeted, or sent an email. Your advocacy made a difference. ASAM's advocacy team will continue to give you many opportunities and avenues to engage your state and federal representatives. Keep your eye out for monthly advocacy update emails from the team and make sure to reach out to them with any questions or opportunities to get involved. They want to hear from you. One of the hallmarks of our annual public policy plenary, and say that 3 times fast, and anyway, is an extended question and answer discussion section, and today will be no different. We have reserved plenty of time to hear from you and to answer your questions this morning. So here's the instructions. To ask a question, you must use the handy conference app. If you have not downloaded it, please do it now. And by the way, it's in the Apple area, it's called ASAM Events. To ask a question, pull out your mobile device and open up the app. Do not text your friends. Instead, select the ASAM 49 Annual Conference 2018 and click on the Happening Now. At the bottom, select the speech bubble that you see, and it says polling. That will open the interface where you can ask a question. To ask a question, select the blue circle with a plus sign on it, type your question in the text box, and hit submit. Now, with further ado, let's turn our esteemed panel and get started. So first, I am pleased to introduce Dr. Jay Butler. Jay was appointed to the Chief Medical Officer of the Alaska Department of Health and Social Services and the Director of the Division of Public Health by Governor Bill Walker in December 2014. From 2010 to 2014, Dr. Butler was a Senior Director for Community Health Services at the Alaska Native Tribal Health Consortium in Alaska, in Anchorage, where he was also a clinical infectious disease consultant and medical director for infection control and employee health. Earlier work includes serving as the Chief Medical Officer for the Alaska Department of Health.
We recycle.
What?
We recycle.
Oh, they recycle. Well, it's you know, there are fewer probably doctors in Alaska, so they just recycle them when they get, you know, okay. Okay, so I got lost by my place in the script now. Okay. Earlier work includes serving as the Chief Medical Officer of the Alaska Department of Health Social Services, Alaska State Epidemiologist, Director of the Centers for Disease Control and Prevention's Arctic Investigations Program, Medical Epidemiologist in CDC's National Center for Infectious Disease in Atlanta, and CDC Epidemic Intelligence Service Officer assigned to the Wisconsin Division of Public Health. Quite a resume. Jay has completed over 23 years of service as a U.S. Public Health Service Medical Officer. He is a graduate of the University of North Carolina Medical School, has completed postdoctoral clinical trainings at Vanderbilt and Emory University, and maintains board certifications in infectious disease, internal medicine, and pediatrics. Busy guy. Moreover, Jay has authored and co-authored over 100 scientific papers and medical textbook chapters on infectious disease, vaccines, public health, and emergency procedures. He has served as the governor of Alaska He served as a governor of the Alaska chapter of the American College of Physicians from 2005 until 2009, and was the 2017 president of the Association of State and Territorial Health Officials. He is a founding member of the New Alaska chapter, yay, and of the American Society of Addiction Medicine. Jay is also the recipient of this year's ASAM Public Policy Award. So having heard all that, please join me in welcoming Jay, who will share his experience as a public health official in Alaska and the ASTHO president.
Great. Thank you. It's really an honor to be here, and I'm going to, it sounds like the sound is working, so I'm going to try to not stand behind the podium. This is part of how, as a public health guy, I get my steps in as I pace back and forth as I talk. It really is, again, an honor to be part of this meeting here as an infectious disease clinician and a public health professional. Dr. Charnas challenged us yesterday to learn from other fields, and I appreciate so much all that I've learned from the people in this room who have spent years, if not the entirety of your professional lives, in addiction medicine. Now, that said, I am a member of ASAM, joined about 3 years ago, and a very proud member of the New Alaska chapter. I think I've been a part of it for all 48 hours of its official existence. We don't yet have the little white ribbons, and my apologies to the Alabama chapter. Yes, we did in our chapter meeting scratch out the Bama and put SKA on your white ribbon so that we could, I'm sorry. It could be an issue in football season, I suppose, but anyway. So I'm going to bring two perspectives today. One is that of the Chief Medical Officer for the state of Alaska. The other is as the president of the Association of State and Territorial Health Officials. I'm actually immediate past president, and sometimes called ASTO. So in Alaska, the perspective that I will bring is one that I'm not saying that we have done it the best. I'm not even saying everything that we have done is right. But as this headline in the Huffington Post says, we've been able to make a lot of progress. When I talk about other states' activities, I have to admit I have a significant amount of policy envy of some of the other states. So it's important that everybody in this room, if you don't know who your state health official is, get to know them. ASTO represents the perspectives of the senior health officials in the 50 states, District of Columbia, and the 8 territories. Now, I'd like to think that all policy is based solely on science and is evidence-driven, but it's impossible to talk about policy without also understanding the political backdrop. So a quick thumbnail of politics in Alaska. I'd say for the past 2 decades, Alaska has primarily been a small southern state. If that's on a background of a longer history that persists to this day of being a Western libertarian state. But also, Alaska has a little bit of the left coast to it. So it's an interesting place to be involved in health, interesting place to be involved in health policy. My job is really interesting. So to frame the discussion, I want to start by addressing 3 issues that are important when we talk about public health policy for addressing substance misuse and addiction prevention. The approach needs to be multimodal. There are no silver bullets. If this were easy, somebody else would have already solved it. And the opioid crisis has certainly put the challenges of substance misuse and addiction onto the public health agenda as well. That is, what are the things that we do at the population level, not just at the individual patient level, to improve health? Second, our approaches need to be multi-sectoral. There are no lone rangers in this. Lone rangers are going to be totally ineffective. And finally, the approach needs to be multimolecular. While opioids are stealing the headlines right now, we all know that there are many other long-standing as well as emerging issues related to addictions that need to be addressed. So this is a sort of complicated graphic, but it helps outline, it helped me be able to frame public health approaches to addressing substance misuse and addiction. And we use this as part of the ASTO President's Challenge to share it among the states. And what it's saying is that the approach needs to include tertiary level prevention. And this includes what are the things that we do to save lives. For those that are nearing the end stage of the rough path of addiction, what are the things that we can do to save lives and to prevent life-threatening complications? Secondary prevention is getting more people into recovery, addressing the needs of those who are addicted, providing appropriate and effective treatment, and removing the barriers to treatment that oftentimes keep people in the cycle of addiction. And then at the base is primary prevention. What are the things that we can do to address both the demand and the supply side of the equation of the drivers that cause people to misuse substances and to fall into addiction? All of this should be built on a foundation of science, of good education for both the public and the professional sectors, and good, sound public policy. So let me go through some examples, mostly from Alaska, of where we have been able to intervene at each of these 3 levels. Let's start with naloxone. There were 2 policy interventions in Alaska that really opened the door to an aggressive statewide naloxone rescue kit program. The first was a law that was passed in 2016 that provided waiver of civil liability to anyone who is administering the drug naloxone in the event of an overdose. The second was in 2017 when a law was passed that provided standing order authority to the chief medical officer to be able to provide naloxone out into the communities. So this really opened the door to push kits out, not just put them in the hands of healthcare providers, EMS personnel, and law enforcement, but also all the way out into the community, into the hands of recovery coaches, clergy, loved ones, family members, and even users themselves, coupling that with the message of don't use alone, so that someone would be available to provide naloxone if it was needed. The kits are kind of an interesting story. If that looks like a pencil box, that's what it is. The kit contains 2 doses of nasal naloxone, which we were able to purchase thanks to a 5-year grant from SAMHSA. A couple of gloves. I'm an infectious disease guy. We've got to have infection control there. A barrier, facial barrier, if rescue breaths are needed, and very simple instructions. Basically, how to do a quick assessment, how to administer the spray, call 911, position the patient on their side. Rescue position. We actually didn't use that term, but have a graphic showing how to position someone so that if they vomit, they will not aspirate. The kits have these stickers on them that if they're in a public place, it's clear what it is, but the stickers were intentionally made to be easily removable. As we sort of field tested a number of variations, we found that some people wanted to be able to carry them without it being apparent what it is. And I've heard this from a number of communities around the country. Some people want to be known as someone who carries naloxone, other people don't. So this can be carried in a purse or inside a breast pocket. If you don't like the sticker, you can remove it. We're in a fiscal crisis, so we don't have a lot of state funds to put into this. Think of me every time you fill up your tank and pay a couple dollars a gallon less than you did 5-6 years ago. So we've had volunteer events to put these together. Now, initially, it was our staff. When we discovered the pencil boxes, we tried to order a couple thousand. They actually were on back order, so we bought out every pencil box in the Fred Meyers within 50 miles of Anchorage. You couldn't get a pencil box. I think my grandkids had pencils sticking out of their pocket as a result of that. But we have had events now in communities, church groups, businesses to assemble these kits. And they have been incredible opportunities to discuss the challenge of opioid abuse and addiction, and an opportunity for people in recovery to be able to share their stories. I think it's important to note, I have not used the term harm reduction. When we talk about naloxone, we need to talk about this as first aid. In Alaska, my group does the training for the state troopers on health-related issues, the AED training, the bleeding control, and now naloxone as well. And I think that's the message we need to get out about naloxone. It is like a tourniquet, and we're coming up on the 5th anniversary of the Boston Marathon bombing, and we think about the number of lives that were saved through use of tourniquets and then immediate referral to definitive treatment. I think that's a model we need to follow. And we have to know that people did not go down the street putting tourniquets on and saying, "You're good," and walking away. No one went along and said, "Oh, you need a tourniquet, but you're going to have trouble driving. You might have an accident and amputate your other leg on the way home. You'll need another tourniquet." No, people were treated with life-saving measures and then referred to definitive treatment. And that's the role for naloxone. Now, another tertiary level prevention, which really is harm reduction, is syringe and needle service programs. This is where being in a red or a Western libertarian state has its advantages. We have never had drug paraphernalia laws in Alaska. So those of us in the infectious disease community and the public health community have quietly been referring patients there for years. Scott County, Indiana happened. And suddenly everybody is talking about syringe and needle service programs. And we're able to shine a light on these programs and talk about the role that they play, not only in preventing bloodborne pathogens, but also getting people into treatment and providing screening, getting people ideally the services they need to enter into recovery. The program that's highlighted here is one that's provided through an HIV social service organization in Anchorage. They have had a quadrupling of their demand. They've actually sort of struggled under the burden of demand. But we've also had more statewide expansion. Dr. Sarah Spencer is in the room. I know she's here somewhere from Ninilchik, Alaska. She's really led a small town program in Homer, for instance. We're also exploring providing syringe and needle service programs through some of the state public health facilities because we are the local public health provider in much of the state. Okay, increasing access to treatment. Let's start with just getting treatment. This is an area of great frustration for me because it was only 4 years ago that I was in the examination room with one of my Hep C patients who was clearly recovery ready. I didn't know what to do with them. I didn't have any place to refer them. And this is one of the reasons why I started, I wonder if there's an association for treatment of addictions. That's how I ended up being an ASAM member, was coming on the website and saying, I've got to learn more about this. And I have to admit, I feel kind of stupid because I've been taking care of self-injection drug users for years, but only recently began to understand the science of addiction and what are the options for treatment. Politics, we are a Medicaid expansion state that has increased access. If you don't like Medicaid expansion, that's fine. But let's talk about other ways to make sure that people have coverage and access to treatment. We have an 1115 waiver that is in process now to try and get rid of the 16-bed IMD limit and to improve access to both inpatient and outpatient treatments. Two real priority areas for treatment in my book is pregnant women, so they are specifically prioritized for treatment, and incarcerated populations. And we've made progress. A little over a year ago, even if you were stable on methadone and came into the prison system in Alaska, you went through withdrawal, you got no treatment, and you went back out on the street. And then we wondered why so many people relapsed and wound up back in prison. We now do allow people who are stable on methadone to continue treatment after incarceration, and we're also providing naltrexone to begin treatment prior to discharge. I think the real model that I'm fascinated with right now is in Rhode Island, where treatment is started earlier during incarceration, and all three options for MAT are available in addition to good wraparound social supports. Another is removing stigma. When I talk to people in recovery, oftentimes I hear it wasn't so much finding a provider, it was just being able to say, I have an addiction. And so we want to tell the stories of recovery because the public doesn't know that there are thousands of people, millions of people in recovery. Most providers who are not in this room don't know that either. So we have been trying to get those stories of recovery out, mostly using social media. We started close to home. This is Dr. Gary Zintek, who works for me. He's our state chief medical examiner. Gary tells his story of alcohol and self-prescription of opioids and how he entered into recovery. Gary is number one, I agree. It is a story that I think needs to be told again and again. We need to change the discussion around recovery. Anchorage Daily News, when Gary was appointed, ran a big headline, highly qualified physician in recovery appointed chief medical examiner. Okay, here's the point where we have the needle scratching across the record. The headline was, physician who lost license in Virginia appointed chief medical examiner. We have got to change that dialogue. So primary prevention, and I'll pick up the pace there. So this is a headline, front page of the Juneau Empire. If you don't know Alaska, yes, changes in the fishing season are above the fold banner headlines. On the left-hand side, you see Mr. Andy Jones, who works for me, demonstrating a drug disposal bag. And I have to give a shout out to Mallinckrodt for donating 25,000 of these bags to us. Being in a frontier state, it's not easy to find a drug disposal site. So we were able to distribute these around the state to use them to dispose of excess prescription opioids. On the other side, you see a description of a governor's omnibus opioid bill. Now, some of these things you may not like. Some, I think, are pretty good. We know that many of our colleagues don't understand the concepts of addiction. And this is where I say, I am preaching as one of the converted. I didn't understand it for years. I didn't understand why my patients did and said the things they did. So the bill requires that a certain portion of the CME that's already required for licensure be committed to the basics of addiction medicine. It also provides some tools that patients can use to help to decline prescriptions for opioids. One of the things we heard from the recovery community is, I'm tired of arguing with my primary care provider about whether or not I need an opioid. So this provides the legal authority for an advance directive that is voluntary, that a patient can have put on their chart, basically saying, I do not want to receive opioids, whether it's because of their own recovery or the concerns about someone else in the home. Now, it talks about prescription limits, and this is where I think we learn from other fields, because I don't like, I'm here as part of the government, but I don't like the government telling me how to practice medicine. But we do need speed bumps. And this is where I think we learn some things from the field of infectious diseases and the experience with antimicrobial stewardship. There's not a lot of data on the impact of limiting opioid prescriptions. And as Paul was saying earlier, we have to be careful about unintended consequences. So in Alaska, the law for, quote, limits, a 7-day limit, is what we call accountable justification. A nurse told me recently of a patient, a student who did what he was supposed to do when he came to school the day after arthroscopy, checked his prescription meds in. He had a bottle of 90 Vicodin. I found out that was sort of their standing routine. Everybody who got arthroscopy got 90 Vicodin. This law puts that speed bump in. It's, okay, if he needs 90 Vicodin, okay, but document in the medical record why that is. And there is a good evidence base for that, for limiting injudicious and inappropriate use of antimicrobial drugs. Also, peer comparisons, being able to see how you prescribe compared to your peers, and suggested alternatives, which we've developed a number of educational materials working most closely with the American College of Emergency Physicians. Real quick, law enforcement has a public health role on the supply side also. This is Marshall. Marshall's no longer with us, but he was still working. You can tell he's a little gray in the jowls there. But Marshall recovered several balls of black tar heroin there, estimated to be about 80,000 doses. So as a public health guy interested in the supply side, I'm glad to see those off the streets. But we can't address the supply side without addressing the demand side. And this is where it gets messy, and this is where it gets hard. And this is where learning from the field of infectious diseases breaks down, because it's not a simple host-parasite relationship with a chain of transmission that can be interrupted, but a complex web of cause and effect. And we have to address things like adverse childhood experiences through programs like visiting home nurses, historical trauma. In Alaska, we're moving towards more formal recognition of tribal government sovereignty, and a number of the other social determinants of health that drive and are driven by substance misuse and addiction. We all have to work together. I will share a quote from a community meeting we had in Utqiagvik at the northern tip of Alaska. An Inupiat elder said, what does it, let's see, how did he say it? How do you eat a whale? And this was not a variation on the proverb that you've heard. What he talked about is no one goes out by themselves to take a whale. No one by themselves brings in a 100-ton bowhead and butchers it. No one eats it one bite at a time. The way to eat a whale is as a community. And I thought, yeah, that's what it's going to take to be able to address some of our challenges with substance misuse and addiction. I'm going to skip over the emergency declarations and just want to close with the need for a multimolecular approach. We deal with legal substances such as alcohol, marijuana for us, that's the left coast part of Alaska. Illicit substances, methamphetamine is a huge emerging problem. About half of our fentanyl deaths, based on some of the emerging data, are also related to methamphetamine. Synthetic cannabinoids and cathinones, this is an area where we need agile laws to be able to support law enforcement to be able to intervene, particularly when clearly dangerous items are on the market. I mean, we can get lettuce with E. coli off the market like that. Why does it take us sometimes years to get bath salts out of the quick pick and the corner grocery? Addressing therapeutic and prescription drugs, including amphetamines and benzodiazepines, and new devices such as e-cigarettes. I don't use the term electronic nicotine delivery systems because I've seen too many instances where e-cigarettes are used for use of synthetic cannabinoids. So I want to leave you with, we have to keep that big picture, because I think that the challenges right now have created an opportunity to define where we go in the decades to come, not only in the clinical practice of addiction medicine, but also in public policy as it relates to substance misuse and addiction. The current environment is one where we clearly have a nonpartisan issue that's crying out for bipartisan solutions. And I think together we can do that. So with that, I know I've gone way over. I was told 12 minutes, and I thought, oh, well, that's how often an American dies of a drug overdose. So really, I've thought that if I talk long enough, I'll save somebody's life. So with that, I'll turn it back. Thank you.
That's great. So we're going to move along quickly. Next, we are pleased to welcome Daniel Blaney Cohen. Daniel is a senior legislative attorney with the American Medical Association and the Advocacy Resource Center. The ARC attorneys focus on work in state and specialty medical societies on state legislative, regulatory, and policy advocacy. In addition to his work in the ARC, Daniel has held several roles in the AMA, including serving as a public policy or a public information officer, policy analyst, and speechwriter. Currently, Daniel focuses on state legislation and policy concerning the nation's opioid epidemic, with a particular emphasis on overdose prevention and treatment. Daniel also covers other pharmaceutical issues, insurance market reforms, and others. Prior to joining the AMA in 1999, Daniel earned his Master of Fine Arts in Poetry from Colorado State University. He is going to do his entire speech through a long poem. You didn't know that, did you? And his bachelor's degree from the University of Arizona. He earned his law degree from the Loyola University in Chicago College of Law. Daniel, his wife, 2 young sons and daughter live in Chicago. Daniel will describe how the AMA and state medical societies are addressing the opioid epidemic across the United States. Please give a warm welcome to Daniel Blaney Cohen.
Thank you. Since I've had my daughter, that picture of my hair has gotten shorter and more gray. So there you have it. I want to thank you again, and I don't know if I'm going to move around a little bit, but I'm going to talk a little bit fast. If I don't make sense up here because I've talked too fast, please find me afterwards, and I will try to slow down. It's absolutely humbling to be here in front of so many physicians. I've worked for physicians for about 20 years. You guys are probably the most humble people on the face of the earth because all you really do is save lives. That's cool. What we're trying to do at the AMA is help you reduce some of the burdens and help you reduce some of the extra stuff that you didn't learn in medical school, didn't learn in residency, but you have to deal with on a regular basis as a practicing physician. If I look down at the clock periodically, it's because I look down at the clock periodically. It's not a George Bush moment where I'm looking at my watch. For those of you who are old enough to remember that. One of the things I want to, and again, I really want to thank ASAM, because it's not just state medical societies obviously working on this issue. It's a numerous number of specialty societies. I'll talk about that more in a little bit. But ASAM staff, I won't call out people by name, Kelly and Brad, and Penny, because that's really not fair. But there are so many people who I've learned here from, and I'm going to encourage you throughout the talk today to tell us more. As Dr. Butler talked about, the advocacy starts with knowing what's going on. We need to know what's going on at an advocacy level to be able to help you in state legislatures. And I'm going to focus on state legislatures. What happens in D.C. stays in D.C., doesn't really, but I'm going to talk about states. One of the things I want to start with is a chart that you've seen before, but I want you to think about it a little bit differently. There's no question about the gravity of this epidemic. Absolutely no question. But I think what we're going to see is that there are numerous questions. There are dozens of questions, if not even more than that. Dozens, not a very high number, but questions aren't being asked about the evaluation of policy. Clearly, the number of people dying from heroin and illicit fentanyl is going through the roof. Those numbers are going to get worse. I think everyone recognizes that here. I'll talk about a couple of reasons why I think it's going to get worse. We've been talking about it getting worse year after year. I hate being right. I'm a lawyer. I actually love being right. But on this one, I hate being right. The number of prescription opioid-related deaths, it's not leveling out. It's still going up. And so even though some people might say there's progress because it's sort of leveling out, that's not the case. Two things to keep in mind as we go through this presentation. The metrics that at least the AMA and I think everyone in here would agree with, the two most important metrics in this epidemic, first, let's stop people from dying. All right, that's the most important metric. And the second most important metric, let's make sure that patients who have a substance use disorder get high quality evidence-based care, get them into treatment. And that includes patients with pain, have access to comprehensive, multidisciplinary pain care. Sometimes that might include opioids. It also will include non-opioid pain care. Unless those two things happen, unless those two treatment-related elements happen, this epidemic is not going to improve. And what I hope to leave you here from, because I don't like to talk about such like really depressing things so early on a beautiful morning here in San Diego, but give you some solutions and some ways that I think that we can make a meaningful difference and provide some examples of where meaningful differences have been made. So take a step back. What are we doing about it? What's the AMA doing about it? In 2014, our Board of Trustees, and thank you to Dr. Gitlow, who I think is here, and others who have been directly involved in the AMA. I broke my rule. I'm not going to name names. I apologize. What are we doing about it? In 2014, the AMA said, you know what? There are a lot of organizations who are doing a lot of things. So let's use the AMA's ability to convene people. Let's convene the top organizations and a select group of state medical societies and figure out what can the AMA and what we call the AMA Opioid Task Force recommend for organized medicine as a whole, recommend for the nation's physicians. And these 6 recommendations were issued in 2015. They're not, and in 2015, this was kind of a big deal. Not many people were talking about this. Since then, as Dr. Butler mentioned, there have been like at least 6 or 7 states that have had emergency declarations. Guess what recommendations they're here? They didn't necessarily consult the AMA, but these have become more or less the standard. And what I want you to think about here is that it's not that these recommendations can readily be agreed to. But what happens next? How are we going to evaluate them? I think one point about naloxone, if it wasn't for naloxone, thank God for naloxone. The AMA had a model bill in 2013. That model bill is pretty much the model for what Alaska enacted in 2016 and 17, including standing orders and other provisions. We worked on that model bill. It's probably literally the highlight of what the ARC has done, sort of. I'm selfish. I helped write it. But the highlight, state medical societies, you in this room, probably a lot of people in this room, helped enact it. The AMA doesn't go into states to help enact it. It requires physicians to say, naloxone saves lives. It's first aid. It's harm reduction. You have to get this into state law. If it wasn't for naloxone, there would be probably tens of thousands of more people who would be dead today. And that's a downer, but it's also a positive thing. Physician responsibility here on naloxone, if a patient is at risk of overdose, co-prescribe the medication. Simple enough. I'm not a clinician, so it's easy for me to say I've never seen a patient. I'd be arrested if I ever saw a patient. But as a public policy, the evidence is unequivocal that naloxone saves lives. And physician co-prescribing is one way that can help assist that. So that's one thing we can do to go ahead and, did I skip one? Nope, I didn't skip one. So quirky. And I like to ask trick questions because I already know the answers. Remember, I'm a lawyer. I like to ask questions I already know the answers to. Which guideline is in best practice policy is a physician supposed to follow? This is today's practice environment. Consider that today, in today's day and age, there are about 35 to 40 states that have one version or another of a mandate to use your state prescription drug monitoring program. About 35 to 40. The conditions vary. In some cases, every time you prescribe a controlled substance, sometimes it's only an opioid, sometimes it's only an opioid and benzodiazepine, sometimes it's only if the MME is over a certain amount. Wow, that sounds like a best practice to me to have so many different clinical indications for using essentially a medical health information tool. That's crazy town. My 7-year-old would say, that's cray-cray, Dad. It doesn't make sense to have that kind of variation, even more so. What evaluation has been done so far? PDMPs are getting better. But what evaluation has been done how have PDMPs helped refer patients with a suspected opioid use disorder to treatment? And not to Addiction Inc., but to evidence-based high-quality treatment such as provided by the medical professionals in this room. That's the policy discussion that we need to foster. Not how often should it be used, when should it be used, and what we're going to do to you if you don't use it. That's the shift we want to make. Prescribing restrictions. CDC guidelines, remember, everybody in this room knows CDC makes clear in the guideline, these are voluntary guidelines. I'll talk about in a few minutes some of the data behind opioid prescribing in the United States. But if you are talk to your colleagues in different states. Is it better care to provide 5 days for an initial acute opioid event? Acute pain, injury? Again, I'm a lawyer. Sometimes I get my medical terms wrong. Is 5 days better? Is 7 days better? Is 3 days better? Is 30 morphine equivalent better? Is 90 morphine equivalent better? Is that what you learned in medical school? Absolutely not. But these legislators understandably have been frustrated by the number of people dying. And so what are the legislators going to do? They can't put medical and clinical decisions in statute. They put in hard thresholds. Now, Aetna, Express Scripts, some of the PBMs here, and many, many others have instituted those hard thresholds. Let me ask you a question. When a patient presents at the pharmacy counter with a prescription, how is that pharmacist supposed to know if it's for acute or chronic pain? Sure, we can do, and states are doing quirky things in law to require physicians to write things like acute pain on the prescription. Pharmacists are calling physicians up and asking, well, what's the ICD-10 code? Because that's real helpful. And then what's happening more and more is that the automatic pharmacy edit that's going to the payer or the PBM is coming back and saying, nope, it's above the threshold, deny. What happens to that patient? This is what's happening in state law. Other quick state trends, and the voluntary non-opioid directive that's in Alaska, it's an interesting policy. What are going to be the effects? What happens with that voluntary non-opioid directive that allows a patient to put into their electronic health record saying, no opioids, never, opioids are bad, they're going to kill everybody. And then that patient presents in a situation where they can't speak for themselves. What happens to the physician if the physician goes ahead, well, they have a bone sticking through their leg, I'm going to administer opioids in the emergency department. That physician's going to do the right thing, but I, as a lawyer, I deal in the world of risk. I think that's a really tricky place to have that voluntary non-opioid directive in that medical record, because what do? Has it been evaluated? It might be a good thing. It puts patient autonomy at the forefront. But what happens? Has it been evaluated? And sort of like all of the prescribing restrictions beforehand, they have not been evaluated. What happens? Here's the data. And the data showing physician progress and other healthcare professional progress. The number of PD queries over the past few years has gone through the roof. 2017 data is preliminary. We're way over. That's cool. There's a 5-minute countdown. Has gone way over 300 million. Keep in mind, it started going up before mandates. Now it's going way up, and then this reflects mandates. But those increases are in states with and without mandates. I would argue, again, what is the question we need to ask about PDMPs? Not whether they should be used, but how can they support the best clinical care? That's the policy discussion not happening. With retail-filled prescriptions of opioids, again, they're going down. They started going down well before any of the restrictions, well before CDC guidelines. But again, how are they being supportive of patient care? Morphine milligram equivalents. This has to do primarily, this doesn't include buprenorphine. But let me tell you one of the unintended consequences that ASAM staff and AMA staff are working closely on because it's infuriating. State agencies, possibly payers, possibly PBMs, are including buprenorphine in their morphine milligram equivalents. And they're doing it to go ahead and send letters and target physicians saying, guess what, you're an overprescriber, you're an outlier opioid prescriber, and we're taking a hard look at you. We might investigate you. And we've received those reports already. Everybody here knows, and CDC has said, and I'll quote, "The dosage thresholds in CDC guideline were not meant to and should not apply to dosing of opioid agonists and partial agonists used for the treatment of opioid use disorder." That's a letter from CDC to ASAM. ASAM did an awesome job. It's on ASAM's website. Use it, download it, have it in your office. But that's not going to stop state agencies and certain people from going ahead and targeting physicians prescribing buprenorphine. The huge unintended consequence of that is that probably not anybody in this room, but it will probably significantly discourage others from prescribing buprenorphine. We talk about the lack of treatment capacity. I'll talk about that in a second. But what we have here is that we don't need more reasons to discourage primary care physicians from prescribing buprenorphine and using their X waiver. So what's going to happen? ASAM staff, the AMA, we're going to be encouraging state medical societies, talk to your state medical society. You need to get on the horn. We're going to get on the horn. Talk to state agencies at the policy level. Say, this is inappropriate. Any state agency, any board of pharmacy, any law enforcement that is using buprenorphine in a CDC MME calculator, stop. I've talked a little bit about chronic pain patients. There is no end to the number of stories the AMA is receiving regarding chronic pain patients just getting eviscerated by this epidemic. Chronic pain patients are getting cut off. They're non-consensually being tapered from high-dose opioids, whether they're stable or not. And so, you know, the pendulum has swung. Clearly, you know, almost 300 million prescriptions, that was high. All right, we're under 200 million. That's a sign of progress. The question to ask is not, should we reduce opioid prescribing even more? The policy question to ask, and we're having more and more data and PDMP data and other data, the question to ask at the state policy level is how has patients' pain improved? How have pain outcomes improved? That is the hard policy question to start discussing. Who is receiving less opioids? And the sad thing is, no one knows. Maybe some pill seekers, you know, those fakers out there, right? That's not how physicians talk. Non-consensual tapering is brutal. And you would never do it to your patients, but this is what's happening out of a fear of being on one of those top 50 lists. Some states are doing report cards really, really well. Some states are doing it as a peer-to-peer comparison. But I'll tell you what, a colleague of mine, a friend and colleague of mine is an oncologist, and she is being compared to internists within her state. She's an outlier. She's kind of scared. She's been targeted by her state. Her state knows who she is. That's not a happy place to be. So why aren't patients getting care? More than 14,000 newly certified waivered physicians. Why aren't they getting care? I think, you know, Dr. Butler talked about stigma, other policy things that you can do. And here's where we have to learn about best practices. Network adequacy. Patients are paying premium dollars for their health insurance plans. If they don't have access to an addiction medicine professional or a family physician or an internist who has treatment and who has decided to use their X waiver, that is not, and accepting new patients, that is not an adequate network. The AMA and the ASAM and others are working to go ahead and go into departments of insurance. This is what you can do with us. Go into departments of insurance and say, you don't need just to certify through some certification or accreditation agency that network adequacy exists. You need to actually monitor and enforce. The AMA, ASAM, others were building those enforcement tools. At a policy level, at an advocacy level, we need your help to go ahead and go into the DOIs and do that. This is hard work. You're physicians. You don't have time to walk around and dusty departments of insurance, and do that. But we need you to. And by virtue of you being at the conference here, I know that you are interested in doing that. Parity enforcement oversight. I have a sneaking suspicion that's going to be talked about a little bit more by our next speaker. But mental health parity and substance use disorder parity. The Mental Health Parity and Equity Act. It's almost 10 years old, people. It's almost 10 years old. How much do you think there have been? I don't know. Have there been 10 enforcement actions in your state over the last 10 years? Ha, ha. As my 7-year-old would say. That's cray-cray, Dad. We need to enforce those parity tools. The American Psychiatric Association has amazing parity tools. If you suspect there's a parity violation, you got to report it. You got to tell your ASAM and AMA advocacy staff. Criminal justice reform policy. Another reason people aren't receiving treatment. Anybody here from Vermont? We have Vermont folks in here? I can't see, those lights are blinding. Vermont has a super cool bill right now that would go ahead and help with increasing access, not only upon entry into the criminal justice system, but throughout the criminal justice system. Super cool. Lack of access to treatment. If your state formulary doesn't have all forms of MAT on the formulary, that is a policy fix. Guess what? Almost no state has all 3 forms of MAT on your formulary. That is ripe for fixing. The AMA has a new model bill. Thank you, ASAM, for help with that on many areas. Again, I shouldn't mention Kelly and Brad by name, but they're awesome. This is an easy policy fix. You're going to hear more about this in 2018 and 2019. A few of the reasons why we have to be optimistic. I just want to point out one on here, and I could put out dozens on here. But Virginia, who's here from Virginia? All right, take a look at Virginia. Their 1115 Medicaid waiver, oh my God, I wish I could say all sorts of cool things about it, but I don't have time. The short story in Virginia, the Medicaid waiver, it's increasing care, it's increasing reimbursement, it's reducing costs. Crazy, isn't it? You go ahead, I'm not going to say my 7-year-old thing again. You provide the financial reality to reimburse physicians for the time that you spend treating patients, and guess what? More patients get care. And you know what? And it saves costs to the state. Improve care, save costs to the state. Radical idea. The AMA is strongly pushing states to look at that 1115 waiver, implement it. There's a ton more to do, but I want to leave you with 2 things. If there's nothing else that you carry back to your states today, evaluate current policy. We have to evaluate current policy. Much of it is just not working, and so we need to evaluate it. And the second thing is work with your ASAM, AMA, and state medical society staff. We need your help to improve the situation. Can't do it without you. Tell us your barriers. Tell us your successes. You're doing amazing work. You're also experiencing amazing barriers. You got to share those. Thank you.
So moving right along, our third speaker we are pleased to be hosting Dr. Alexandra Duncan. Alex is a senior officer with the Pew Charitable Trust's Substance Abuse Prevention and Treatment Initiative, which works on federal and state initiatives to reduce the inappropriate use of prescription opioids and to increase access to evidence-based treatment for substance use disorders. Before joining Pew, Dr. Duncan was a research associate at Impact International, where she supported the Center for Consumer Information and Insurance Oversight. She did this on issues related to the Affordable Care Act, compliance with prescription drug, and non-discrimination regulations for high-cost medical conditions. That included opioid use disorder, as well as evaluation of health programs. In addition, previously she was a senior analyst for ABT Associates, working in the division of U.S. Health, Public Health, and Epidemiology practice on several projects related to HIV testing and the integration of HIV treatment in the treatment of substance use disorders. Alex completed postdoctoral training in drug dependence epidemiology at Johns Hopkins University's Bloomberg School of Public Health after earning a Doctor of Public Health degree from the Columbia University. She also holds master's degree in public health from Tulane University and a bachelor's degree from Bryn Mawr. Alex will share with us about Pew's work in several states to strengthen their addiction prevention and treatment services. Thank you for joining us today, Alex.
Great. So good morning, everyone. I'm Alex Duncan, and I am pleased to share with you about Pew's technical assistance that we are providing to states in order for states to increase access to substance use disorder treatment, more specifically opioid use disorder treatment. Pew is a large nonprofit research and policy organization with a mission to help states and public leaders identify evidence-based solutions to pressing public policy problems. Pew's Substance Use Prevention and Treatment Initiative has two main goals. Our first goal is to reduce the inappropriate use of prescription drugs and increase access to treatment, including medication-assisted treatment. Today, I will talk about Pew's technical assistance to states, where we are assisting states in increasing access to timely access to comprehensive, evidence-based, and sustainable care. Pew has been developing a technical assistance model for the last 10 years or so, and we are now applying that to substance use disorder. We provide light touch technical assistance, which I'll describe in Mississippi, and that light touch technical assistance is really focused on a very specific problem for a short duration of time. We provide in-depth technical assistance to some states, which includes data analytics support, policy research, and a facilitation of a task force process. Our in-depth technical assistance begins with a needs assessment, where we then develop targeted and specific policy options for the state to move forward to increase access to substance use disorder treatment. And then we assist the state with policy change. And that policy change could be regulatory, it could be legislative, or some other administrative action. The in-depth technical assistance includes Pew's support for 12 to 14 months at no cost to the state. In terms of examples, we'll talk about Mississippi's light touch technical assistance and then in-depth technical assistance in Indiana and Wisconsin. For Mississippi, Pew was invited by the Mississippi House Medicaid Committee to review some treatment-related legislation. As part of that very short duration technical assistance, just a couple of weeks, Pew provided several recommendations. Two highlights are the state should consider increasing methadone access to treatment and reimbursement by Medicaid. Also, for Medicaid to remove prior authorization for FDA-approved medications for the treatment of opioid use disorder. For Indiana, one of our in-depth technical assistance states, the challenge in Indiana is the state has a legislative moratorium on the number of opioid treatment programs in the state. Indiana lags behind other states in terms of OTPs per capita. With the 14 OTPs currently in Indiana, 5 more are slated to open any day now, in April and in May, which is great. 13 of those OTPs, of which there are state data, provide buprenorphine. 8 of those 13 provide buprenorphine. Another challenge with the OTPs are that patients travel on average 30 miles one way to get to treatment, with at least one of the OTPs reporting that patients travel around 100 miles one way to get to treatment. Governor Holcomb is very committed to addressing this crisis, and in his 2018 legislative agenda, he actually had several substance use disorder related initiatives. As part of Pew's recommendation, we requested and supported the state in their efforts to increase the number of OTPs in the state. Governor Holcomb recently signed legislation to increase the number of OTPs by 9, with the goal of patients traveling no more than an hour to get to treatment. In Wisconsin, another one of our in-depth technical assistance states, a 2016 Wisconsin needs assessment found that only 23% of patients that had substance use disorder received treatment. Any comprehensive system to address opioid use disorder must rely heavily on community-based providers. As part of Pew's recommendation to the state, is for Wisconsin to build a treatment system that engages community-based providers, as well as federally qualified health centers, and provide a support system to treat patients that have folks such as yourselves providing that specialized care when needed and support for providers in the community. This system centers around a hub and spoke program that many other states have used. Pew will be supporting Wisconsin with their continued work around the development of a hub and spoke program by supporting an advisory council, and as part of that work, Pew will connect that advisory council with many of you in the room as experts to understand some of the barriers to developing a hub and spoke program, as well as costs and payment reforms that may be necessary. Pew will support the state in assessing best practices that many of you use and that are used widely in both Vermont and in Rhode Island. Let's talk for a second about some of the opportunities for states. With Pew's work in states, we have realized that partnerships between stakeholders and government are essential. Medicaid in particularly is a key stakeholder in this work. Medicaid coverage of medication-assisted treatment dramatically increases access. But what we hear from providers is that reimbursement for Medicaid is insufficient at times and serves as a barrier for providers taking on more Medicaid patients, as well as a barrier for treatment centers that want to expand to increase the access that patients can receive. With respect to comprehensive payment reform, reimbursement is a concern for multiple stakeholders and will be necessary for both private and public payers to engage in this conversation. One of the things that providers and public and private payers talk about is that it's more than just reimbursement. It's about benefit design. It's about bundled rates. So all of these are factors in comprehensive payment reform. States should also consider workforce capacity related concerns. For example, are there adequate number of specialists, primary care providers that are willing to prescribe buprenorphine and naltrexone? Do you have the right distribution of providers in rural areas and other geographic centers, sometimes in frontier communities? What about mental health counselors? Do you have the appropriate number of mental health counselors to meet treatment demand, as well as peer recovery coaches? States can consider what needs to happen to increase the number of providers that have buprenorphine waivers, and for those that do have buprenorphine waivers, how can states encourage people to prescribe to their capacity? Special populations, such as pregnant patients and persons currently and formerly incarcerated, sometimes require complex treatment. And it is important that there is a support system around these patients and that there are comprehensive behavioral health services and psychosocial services. A couple of examples just for me to close. So Vermont's Hub and Spoke program really takes note of the special populations and provides a system of care. Ohio Medicaid partnered with an insurer to ensure that persons leaving the prison system have adequate coordination of care. And we already heard about Vermont's Medicaid program really taking on comprehensive payment reform. And so I'd like to thank you for your time, and I am happy to take questions at the appropriate time. Thank you.
Okay, so Just a reminder to you all, if you have questions, please put them on the app and they'll come forward to Kelly and Brad up front, and then they'll be pushed up to the table here. And before, we'll start with a few questions that have been sent forward by our staff, so you know they're really good. So the first question of our panel today is, additional funding is an essential component if we're going to reverse the catastrophic trend in opioid addiction. Unfortunately, there may be members of Congress who are reluctant to further increase funding for addiction treatment because drug-related deaths have not decreased despite previous increases in funding. Can you speak on as to why we haven't seen these changes in death rates, and what ASAM, more importantly, what ASAM and ASAM members can do to advocate for the importance of more funding?
I'll jump in there. So first thing that comes to mind is the vision that we've talked about of saving lives and addressing addiction. And there's a quote that I really should run down, but I know it's been attributed to Congressman Hal Rogers, that vision without funding is hallucination. And I think that is very, very accurate. I think we also need to recognize that this is not a flu pandemic. It's not a matter of developing a vaccine and getting it into as many arms as possible. This is a much more dynamic situation. And the emergence of illicit fentanyl is as if we were in a pandemic and suddenly the hemagglutinin type changes. And oh, by the way, it's acquired drug resistance also. So to think that, you know, one or two measures is going to result in this just going away, I think is very naive. But it also fails to recognize the fact that the epidemic that we're dealing with in 2018 is different than the one that we were beginning to recognize in 2013.
Right. Yeah, and you know, and I'd add the Congress has has provided money, and they have demonstrated a commitment through the Comprehensive Addiction and Recovery Act 1.0, and now there's 2.0, and there are hundreds of millions, if not billions of dollars that have already been appropriated. And so I would like to think that some of those programs, so there are two things. One, a lot of that money that's been appropriated, it hasn't gotten to the states. It hasn't gotten to the state territorial health officials in the states and other programs within states. But for that money, so we have to figure out how to open up the pipeline, right? States need the money. But the other thing is that for programs that have already received the money, did they work or are they working? And if that is, and that's a public-private partnership. If those programs are working, let's hear about it. If they're not working, let's hear about that too, so we don't throw more good money after bad. Maybe every program is working, but we don't know what is working right now. What we do know that's working, again, I'll go back to Virginia's 1115 waiver. We know that's working. Saving the state money. We know that naloxone distribution is cost effective and it's working. We know that MAT is cost effective and it works. So let's emphasize not necessarily where do we need more new money, but where do we need to put additional money. There are bills in Congress for loan forgiveness, for example, for treatment in more rural areas, and that's not limited to addiction. As you know, somebody from Alaska in every state that has rural areas and underserved areas knows. But loan forgiveness programs, that works to get physicians and other healthcare professionals to those areas. Focus on what works.
So I just have a follow-up question to that for any one of the panel. Do we have metrics that determine what works? Are there metrics that can help us say this is working and this isn't?
I'd go back to the evidence is unequivocal that MAT promotes recovery and sustains recovery. So I think we have one metric right there. I think on other programs that it's emerging. PDMPs, the mandate issue, it's not going to be a question in a year or two because everybody's going to be using it, whether there's a mandate or not, because they're good tools. But I'm not aware, and maybe the physicians in this room could help us understand, how are you using PDMPs in your practice to most effectively help patients with a substance use disorder? If you are doing that in your practice, let us know. So that way we can support programs that go ahead and direct more funding to those efforts rather than have the question be, well, should we do it every 2 months or 3 months?
Sure. And obviously abusive use of PDMPs is not the answer. All that does is push people out and push them into the heroin side from opioids.
Yeah, and I think when we look at the metrics, I mean, one of the most basic ones, William Farr in the 1840s, sometimes called the father of epidemiology, said, death is fact, all else is inference. So looking at the mortality related to drug overdoses is important with good data. And I recognize that there are challenges in some states, particularly where there are county-based coroners, even counting the cases correctly.
Correct.
So we have to recognize that. But beyond that, there are issues such as using databases that are existing now, including sentinel surveillance, which actually in many states, including my own, was created as part of bioterrorism surveillance. We're able to look at some of the specific numbers of EMS runs related to overdoses. Also, we've used that for a cluster, tracking an outbreak of health events related to synthetic cannabinoids. And we actually found, if I can say again, one of the impacts of the fentanyl influx is unlike in the past where deaths have sort of smoldered along, we now see outbreaks. Because when a batch of heroin comes in, which is actually primarily fentanyl, or there's counterfeit pills that hit the street, we are now seeing that there's a peak in EMS runs, and within a few days we'll begin to see deaths. And so we're trying to use that as a way to get word out to the public so that users are aware, and also to law enforcement so that they can be aware as well. Naloxone distribution, the number of doses administered. We don't put a lot of strings on our kits, so it's not a great metric, but at least having the anecdotes helps. The number of people who are entering into treatment, so we use the Medicaid database to be able to look at the number of people who are receiving, particularly buprenorphine and naltrexone, the number of claims. We like to see that line going up. So, because we know that the majority of people who have an addiction are not in appropriate treatment yet.
Yeah, and I say another, one policy that states are increasingly looking at is using the PDMP and tying, and with coroners, and tying an overdose event to whether or not that person had a prescription for an opioid. I would say that there are serious questions about causation and correlation to that. On what, whether that opioid prescription led to that overdose event. But that's something that's being pushed, in the law enforcement community primarily, not solely, but primarily. What about a metric, and again, I'm being a little off the edge here, but what about a metric that if somebody has an overdose event, what about tying it back to whether or not that patient was able to access addiction medicine treatment?
Yeah. Great. We would love to see that happen. So we've got tons of questions here. So several priority groups have already been mentioned, those pregnant women and those in the criminal justice system. And a great question came in, that's asking, what about adolescents? Most addiction starts in this age group.
At the policy level, just real briefly, we're seeing a lot of state policies at the, both at the statutory and regulatory level, requiring informed consent for any opioid prescription for minors, for example. I would also point to one of the reasons we can be optimistic. Boston Children's Hospital, I don't know if Dr. Sharon Levy is here. God, I always do that with names. But she's amazing. She's one of the hundreds of physician champions who are here in this room. She's initiating or she has been one of the physicians to initiate a citywide or system-wide pediatric addiction medicine coordination of care effort. So there is a best practice going on right now in Boston. And granted, I know Boston has about 2 million healthcare professionals there. But she has the protocols in place, and she's developing the SOPs so that kind of standard of care and practice, maybe it has to be adjusted a little bit differently in other places. Not every city has a pediatric hospital or could afford a pediatric hospital focused on addiction medicine. But it's happening. And so that's the kind of thing from the AMA's perspective, as at a policy level, I look at that policy and I get into the guts of that policy and try to figure out, or of that practice, and how can I translate that practice into policy? That makes my job a ton of fun.
Great. And I'd just add that primary prevention has been where a lot of the policy focus has been on adolescents, but I think this is a really exciting area in terms of scientific development. I kind of wish we had Wilson Compton back up here right now, because the disease of addiction in adolescent may be very different in terms of the neurophysiology as well as the therapeutic approaches compared to the 40-year-old that has been using heroin for 10 to 15 years. So there's a lot that we need to learn about the adolescent brain and substance misuse.
And with respect to youth, I encourage folks in the room to let policymakers in your states know that that is an interest of yours. With the work that we do at Pew, we hear a lot more around prevention for the young people. And so it's important that it's communicated that folks have an interest in thinking more about treatment for youth and communicate that up the chain from a policy perspective.
Great, and I'm going to follow that up with a question for you, Alex. This is a great question as well for all of us in the audience. Multi-sector approaches are often discussed as the best practice for comprehensively addressing addiction issues. But many times folks tend to work in silos of industry, academia, clinical medicine, etc., which just continues the status quo. What recommendations do you have to form new multi-sector partnerships to accelerate intervention?
So many states have a commission or a task force that is usually overseen by someone in the legislature or the governor, him or herself. That's an opportunity for people to engage. Those are usually task forces or entities that are multidisciplinary. There are clinicians, law enforcement, people from Department of Corrections, and that entity really serves to answer questions, to think through policy change, and be an avenue for clinicians to express some of the concerns that you're seeing on the ground, so that way that can be funneled up through potential legislation and administrative action.
So just a quick follow-up on that. And so if there's someone in the audience today, and I hope there are many, who are saying, I need to be involved in, in these collaborative efforts, what would they do when they go back home? What should they think about doing? Who should they call? I know that's difficult in every state, but your thoughts on that? Yeah, I mean, every state is a snowflake.
So with that, it's important that you connect with your governor's office to see if there is a commission or a task force in your state. There usually is. And then you can connect with the leaders of that task force to see how you can plug in. A lot of times, perhaps you can be a guest speaker, or you might even be invited to be a member of that task force or commission.
Great, super. I have another very interesting question, just kind of shifting the conversation a tad. With a focus on opioids in the media, many elected officials have not I'll try that again. Many elected officials have not paid any attention to this other substances of addiction, particularly alcohol. What should ASAM members do to broaden the conversation of addiction to address other addictions outside that of opioid use disorder?
Well, I mean, far be it for me to tell ASAM members what to do, but I would say ASAM members are doing it every day. And in terms of media, I mean, how many people are tired of the stories of mom gets arrested because she passed out at the truck stop and baby was in the back seat. Any number of version of that story, or guy arrested with like 4,000 bags of heroin in his stomach. I get the reason for those stories, but there has to be an equal effort by organized medicine. And granted, AMA needs to do a better job of this as well, but an equal effort within organized medicine, and I would say within the public health community, to talk about what actually needs to be done. Talking about the benefits of treatment is not a sexy story. But talking about, and I'll just give one example, a physician, God, I won't name her name, this morning was telling me about, she's from Maryland and she's sitting here in the front row, that, Maryland ended prior authorization for MAT. That is an enormous public policy success. Guess what? That means more treatment for patients. Organized medicine has to figure out how to tell that story. And for other substances, the conversation about reducing stigma, there's been success in the epidemiological world and public health world about reducing risks of all sorts of youth behaviors. So how can we tell that story that the models that physicians have led can also be applied here? Organized medicine needs to do a better job. Would love your suggestions.
If I could just add, part of the message is that addiction is a health condition affecting the brain. If you want to call it a disease, that's fine. I don't want to get into the semantics of that. But we have to do a better job of communicating that addiction is not just bad habits, it's not just moral failings, but it is a health issue. Just like cancer is not a bad habit because you smoked. We also need to help everyone to understand the effects of addiction that are manifest because of how the brain is impacted.
So when we're asked to speak on a particular issue around the opioid crisis, should each of us say, but opioids are yet one part of a larger problem? Should we say alcohol and tobacco products contribute more deaths than the opioid problem? As you said, Daniel, it's not particularly sexy, but it is an issue. And should that be part of the conversations we provide when we're interviewed about the opioid use disorder problem?
I'll quote, Dr. Patrice Harris, who chairs the AMA's opioid task force, that it's not either or, but it's and both. Yeah. And so, we don't want to get into we don't want to start comparing my disease as worse than your disease, right? But we want to explain to reporters, and we want to explain, and by reporters I also mean public health officials who don't have the knowledge, don't have the experience of this, that we're talking about medical diseases that have public health solutions, and it's multifactorial. There are lots of things going on, but as every physician here has probably been trained, you don't try two solutions at once. And so each one has to be looked at individually to see what the effect is. So when you're talking to reporters, take your time. It's and both.
Yeah, and data really supports that. In my state, more people die of alcohol-related disease than drug overdose. But more years of potential life lost occur due to drug overdose because younger people are disproportionately impacted by drug overdose. So it is not an either or, it is an and.
Another thing with respect to all types of substance use disorders is creating a treatment system that is comprehensive and addresses all substance use disorders, not just the opioid crisis. Of course, that's what we're talking about often because of what's going on in the media. But changes in the substance use disorder treatment system will take into account emerging drug use trends. And that's important for us to keep in mind and to communicate with the media.
Great. I think we're kind of coming near the end, so I have one really, I want everyone to leave with fired up to figure out what their next steps are in public policy and especially regarding prevention. So this is to all of you. I'd like you to think about this question so we can charge the audience as they leave. What is the single most important thing ASAM members can do to make a difference at the state level?
Yeah, I'll go back. Tell your ASAM staff about your successes. Tell your ASAM staff about your barriers. Sharing both of those will give ASAM staff the advocacy tools that they need to demonstrate both the positive side and then where the challenges need to be overcome. You have an amazing staff. Give them the tools, those kinds of tools that they can use in Congress and in states.
And I'll just add to that, going back to some of my opening comments, get to know your state health official, communicate those concerns. You know, it's been 4 years now since I laid hands on a patient. So I see the forest, but I may not know a tree if I ran into it. So I really need the perspective of people who are in 2018, day after day, taking care of patients, as well as those who are taking care of patients with addiction. So I, as a state health official, really need the perspective of people in this room. And I think I can say for all of my colleagues across the country, they would share that feeling.
And for ASAM members to not be afraid to engage in policy. Policy helps with sustainability, and engaging with multiple stakeholders, including those commissions or task forces in your state, are key for moving the needle.
Great. Before we stop, I want the ASAM staff that deals with public policy to stand up. And afterwards, I want you to kind of flood them with questions. So if you could stand up, have them stand up. Where's Brad? Did Brad leave? Well, Brad left. He somehow figured out. Well, thanks for a great conference, and I hope you have a great day.